Is it rolling, Bob? Which you think we're on? Hi, everybody. Alec McKenzie here. I've been asked to do the Grand Round moderating until I get it right, and so I'm back again. And we've got ends of the age spectrum. Me moderating, and we've got two excellent PGY3s presenting today. Nasreen, Irfan, and Simran, Dhanju. And it's more or less a caveat emptor. Don't always believe what you necessarily read. Reality check that they're going to give us this morning. And so just context, just before I bring Nasreen up, she just had her lovely baby at home. Her husband's a family medicine resident. She's a senior medicine resident on Red Team. And she did advocacy rounds last week, and we're asking you to do grand rounds this week. So give it up for Nasreen. Come on down.
Hi, everyone. Good morning. Our topic today is going to dive a little bit into research and a lot of the papers we read, and do we really believe what's being written, even if they're from reputable journals and they're peer-reviewed? So our title is When Literature Lies, Lessons in Research Integrity from Fictional Pediatric Case Reports. I'm going to do the first half of the presentation, and then my colleague Sim will be doing the second half. So our learning objectives for the presentation is to apply appraisal skills to pediatric literature with a critical eye, recognize markers of compromised research integrity, understand how flawed evidence influences clinical practice, and I think that would be very surprising, use of a practical framework for safe adoption of new evidence, and reflect on the ethical responsibilities in scientific publication. So I'm going to start with a case. I have a 1-week-old boy in the emergency department with poor feeding, increasing lethargy 2 days. He was born term, uncomplicated. It was a repeat C-section for the mom. APGAR was 8 and 9. Birth weight was 3.2. 2 healthy siblings, no family issues. We have our vitals here. His blood pressure 75/45, heart rate's 120, shallow respirations, rest rate is 16, poor responses to stimuli, weak suck. We did a septic workup for him. It's negative. When they did urine for him, we got positive opioids. Diving further into that, a serum morphine was 55 toxic level, and they treated this baby with naloxone, who improved. And when you get a little bit more history from the mother, she took Tylenol 3, so acetaminophen coating after the C-section. And that was basically for the pain that she was having. She took 1 to 2 tablets 3 to 4 times daily, good pain relief, but she was constipated and drowsy. And this was the explanation for why the baby had opioid exposure. When you get a little bit deeper.
To be clear, it was the breastfeeding of this baby that
Yes.
caused the opioid exposure?
Yes, and just to mention, mom was breastfeeding, so that is what was the hint for the opioid exposure. When you go deeper, basically, some people are called ultrametabolizers, and high levels of opioids pass through their breast milk. Codeine is a weak prodrug. The effects of codeine can be very detrimental when it metabolizes into morphine in a neonate. And when you look at the ancestry, 1% of Northern Europeans, 8% of Mediterranean, and almost a quarter of Middle Eastern, South Asian, and African hold this ultra-metabolizer morphine status. So this was recognized. The infant showed lethargy and bradypnea from the overdose. Maternal symptoms for her also showed opioid toxicity. Sepsis was misleading. And so what this kind of taught us was that codeine should be avoided during breastfeeding if possible, especially if you're suspecting that they're an ultralyse metabolizer. So the question from this case is, would this case actually influence how you prescribe or counsel? If mom is coming to you and she has pain post C-section and she wants to breastfeed, would you be giving that Tylenol trees? So I'll just put it to the room. Would it affect your prescribing if you heard this case and what happened? So definitely it did, but the controversy is actually this case was fictional. So despite it being fictional, it was published in a few reputable journals, including Pediatrics and Children's Health. It was not labeled as fictional, and it was cited with lit reviews and guidelines. But that actually wasn't the beginning of this. So this is a case report from the Pediatric and Children's Health Journal that was published in 2010. So when we go into the beginning of this, actually it comes from a 2006 paper that was published in the Lancet, which described this 13-day-old baby who died in Ontario. And it focused on this poisoning in 2005 that a baby boy had been, mom had been prescribed Tylenol 3s, and the baby boy passed away due to morphine through the breast milk. And then later when we dive into it, basically there was claims that actually mom was an ultra metabolizer, and that's why it was possible that this could happen. So this was the Lancet that published the original case in 2006 from a 2005 case. So years later, a lot of toxicologists and pharmacologists have dissected this, and they concluded that it's pharmacologically implausible to have been caused by breast milk alone, strongly implying that the infant directly ingested the medication. And when you think of a 13-day-old infant, that is pretty hard to do. In the original case, actually, Children's Youth Protection was involved. So these are some of the scientists who were able to disprove that this was possible. We have 2 studies. And basically they disprove that there is no way that your breast milk can transfer morphine into a baby, even if you are an ultra metabolizer. So why does this matter? Well, we have a case report from 2006 from the Lancet, where then Pediatric Children's Health took that same case, and then it was actually put into citations, reviews, changed policy, as we'll further discuss, used in teaching and training, in OBGYN training, and then clinical practice. So you can see how one case, even if you retract it later, can actually just kind of ripple through the medical community. So the damage had been done. The study was highly influential, prompting global health warnings and changing of medication labels. Many advice to nursing mothers was to forego Tylenol 3s and actually be prescribed more potent and addictive opioids during breastfeeding. So the FDA actually stated on its public health advisory of this case report. The American College of Obstetrics and Gynecologists also published several case reports, cited this as the original, where FDA directly changed the labels to use as a warning in breastfeeding is not recommended. And Health Canada also followed in this trend in 2008, warning nursing mothers about the risk of morphine through breast milk related to maternal codeine use. So just in case you don't believe me, here's the AAP site warning about the effects of codeine in breastfed infants. Here's Health Canada, use of codeine products by nursing mothers. So you can see how one case report actually kind of just ripples through it, and it actually changed policy. And it's crazy because even when it was retracted, the policies didn't change. When we talk about Pediatrics and Children's Health Journal, that is like our most used journal as pediatric residents. So there was another concern in the ethics of how this was done, is that the case reports that have been published in this journal were not disclaimed as fictional learning case reports. And so a lot of people actually believe these were true case reports. And this had been going on for 25 years. They also use citations and influence. And then finally, when someone asks the question, is this, yeah?
Sorry, why even have
We're going to talk about that. Yeah. So there was a question from the audience of like, why even have fictional case reports when we have so many real cases? I think that's what we're going to dive into. But yeah, so and the problem with this is that if you are putting a fictional case report, you have to disclose it's fictional, because there are people who have changed their practice based on case reports. And this case in particular, baby blues, why you have a lethargic neonate, did change practice for a lot of pediatricians and obstetricians. So this is just for the Pediatric and Children's Health Journal, which has been cited multiple times. And so this has been going on for 25 years. It changes policy, it changes our education and teaching. And then if you learn the wrong thing, you teach the wrong thing, you're going to do the wrong thing. So I'm going to let my colleague Sim take over. He is online, so I'll just make sure you guys can hear him.
Yep. Am I coming through?
Yes.
Perfect. Let me just see if I press this, does that give me? No, that's not it.
And Sim, use your outside voice because you're not that loud here.
I'm
Yeah,
not that loud. Okay, I'll try to talk up a bit. I'm just trying to get control of the presentation.
Sorry, we can't do that. Rachel, can we give him control?
Maybe click it and then click the arrow rather than clicking the arrow. Does that help?
No. Oh, wait, hold on a second. Maybe this.
Okay.
I think you're on.
Okay, I can be your
All right.
hands if you tell me
If you
next.
don't mind, just
No, no
sure. All
problem.
right.
I'm up here anyway.
Perfect. Appreciate it. Thank you. All right. So yes, good morning, everyone. Thanks for joining us. So apologies, I can't be there in person. I'm out on elective right now outside of Ottawa. But thanks, Nasreen. So we'll kind of just lead into the next part of the presentation where we'll kind of look at what are kind of the pitfalls with the research process as it stands today and present a bit of a framework of how we can manage some of those issues. So one thing I think is worth acknowledging just as kind of an important first step is that there's probably a perception amongst many of us that just because something is peer reviewed, it's automatically true, or it is something that the conclusions of which we should kind of just take at face value. And that's not really what the process is designed to be, nor has it ever really been the intention. Peer review itself is really fundamentally a quality control process. It's to answer the question of whether or not research is reasonable. And it's not really looking to confirm the results or findings that have been presented. So, like anything involving humans, there's inherent biases, whether that's
Just one moment,
Just,
Sim. We're just
IT's buggered it up here for you.
we're just
okay.
having a little. Oh,
Okay, good.
got it.
Okay,
Okay.
go. Keep on going.
Okay. So yes, so whether that's inherent biases behind what a particular journal is interested in publishing, down to reviewers themselves and their own opinions, slash their own limitations in terms of how much time do they have to actually conduct the review, and recognizing that oftentimes the reviewers don't have access to the raw data. Really what they're presented with is stuff that's already been processed and presented in a way to be convincing. And then there's a certain amount of trust that we as physicians will place in certain journals and certain authors. And there is a certain amount of authority that particular publications and people will have that, again, we probably have a tendency to take at face value. So am I able to shift now? I still can't change the slides. So kind of just like what Nasreen was saying earlier, just a sort of cascade of how these things happen. And really this peer review process is at the foundation, like when we're submitting research like case reports, and its ultimate implication goes all the way down to how we practice, what are our guidelines, how are we teaching the next generation. So just to kind of put into context as to why having a bit more of a skeptical approach to peer review is helpful. Next one, please. So just a brief question to the audience, and if people in the room want to shout things out or people in the chat want to just type things in, what are some of the assumptions that you might make when you're reading something that's peer reviewed?
That it's true?
You don't
Yeah.
know it's true, but you want to believe it's true. So you're already making that assumption.
Yeah.
That it has been rigorously peer reviewed and fact checked. So yeah, I think that's the fundamental assumption that one makes.
Yeah. In case for those who can't hear, we're getting answers that are like that it's been fact checked, peer reviewed, that lots of people have looked into this, and so it must be true.
Exactly. And I think that's a reasonable assumption to make, especially when we attach this moniker to an article. And other things you probably think of, is this representative? Is this reproducible? Is this accurate? And really the peer review process itself doesn't necessarily establish all of those parameters. So that's probably why it's worth keeping in mind that it's not a foolproof process, and we should be careful about what we're thinking, what we're deriving when we look at that title. Next slide, please. So that brings us to kind of the big solution that's also been a big trend in the last decade or so, evidence-based medicine, which to briefly recap is just a combination of, actually, if you want to just go to the next slide. So just to briefly recap, it's a combination of using sound clinical judgment alongside relevant scientific research, and then incorporating our patients' values and preferences as an approach to practicing healthcare rather than relying on things like intuition or tradition or what is conventional knowledge or what have we always been taught is true. So actually investigating what is happening, why it happens, and using that to inform how we're practicing medicine itself. And then if we can just move to the next slide. And when it comes to evidence, I'm sure everyone's familiar with this, but just to kind of recap, not all evidence is equal, and some evidence is more equal than other evidence. And in particular, I want to just draw everyone's attention to things like case reports, case series, and expert opinion, which I thought was kind of funny that those are at the bottom of the pyramid. So really what we know doesn't often actually stand up in terms of what is considered robust knowledge. And really the approach when you're looking at a study is to divide it into what is considered unfiltered versus filtered. So the sort of the bottom half of the hierarchy is all unfiltered, meaning these are typically just single studies. They don't represent necessarily the most broad population, most reproducible results. And then as we ascend up into the systematic reviews, that's where we start getting filtered information. So now we're combining multiple studies, and that's what gives these greater evidence and greater strength for us to base our clinical practice on. And if we go to the next slide. And obviously, there's strengths and limits of all of these different types of studies and different types of evidence. We'll just briefly talk about case reports since that's most relatable to the topic today. But it's not to say that case reports are bad and we shouldn't do them. They do have a role, they do have a purpose. Because they're relatively simple to do, we can have them work for more early signal detection. Certainly rare diseases, just because of their population size, will probably always start off as a case report. And they're a good way to kind of start generating hypotheses and collecting data, forming data sets, and having kind of a baseline amount of information to go on to do other studies. Limitations, though, are always important to consider. And number one, you can't ever really determine causality from these studies. You can only infer that there's some correlation. You're always subject to a selection bias, and case reports can sound very convincing and sound very significant. They have a good narrative behind them, but that doesn't necessarily mean that they are robust. And they're often not generalizable because they're just representing one population at one point in time. So it's hard to interpret their results and apply them to a wider practice without really creating an ecological fallacy. Next slide, please. So when it comes to critical appraisal, there's 6 key questions that we found that should really kind of factor into our decision-making around whether or not we want to put faith in a piece of research. So number one, is the methodology sound? Does the reported study type fit the question they're trying to answer, and are the conclusions from it reasonable? So that's number 2. Is the proposed mechanism or the proposed conclusions actually biologically plausible with evidence and knowledge that we've known to be true for decades, if not centuries? Is any of this reproduced? Has anyone else independently confirmed these same findings, or are we really just looking at one study? Have the authors appropriately explained and explored bias and confounding as a contributor to their findings, because that is always present in research? And ask yourself, would I change anything I'm doing based on this single study alone? Just because something is presented as statistically significant doesn't necessarily mean it's clinically significant. And it may not actually have much impact on your outcomes for your patients in your own practice. Next slide, please. Things to be wary of if you see that should kind of trigger a red flag in your head. If people are making really, really strong conclusions from weak data, if there's a lack of transparency, so we're not being told what was the study methodology, how did we recruit patients, how did we narrow down our results, what was our statistical analysis process. All of those are things that should make you a bit suspicious about the conclusions that are being reached. And then again, if the conclusion or if the potential impact, clinical impact, doesn't quite match what we're seeing in terms of the evidence as well. If where people are kind of picking and choosing what they're reporting and telling us about with respect to their study size. If the sample size is small and they're making claims about how this applies to the general population, if this hasn't been reproduced or if the reproducibility is poor, and if there's no disclosure of conflict of interest, because that would be a huge bias that is going to definitely color the way a research paper is presented. And the next slide, please. And so why is it that we get misled? Why is it that we as smart people are falling into some of these traps? So some of the things we've kind of already talked about. Authority bias, we are probably primed to trust certain people, certain journals above others. And I think that's why this example being in pediatrics and child health was so kind of visceral for both of us. Publication prestige, again, kind of falls into that, the fact that the journal of our professional society was involved in kind of distributing false case reports, and none of us really thought to question it, I think really speaks to that. Confirmation bias, sometimes we just want the reassurance that what we're thinking is right, and some of that is probably being a little bit uncomfortable with certainty, which comes into number 5 as well. And then just pattern recognition and heuristic thinking, and a tendency for us to, we are trained to sort of think, well, if it fits, it probably fits, but that's not always necessarily the case. Next slide, please. And so then we'll kind of talk about things at a greater level in terms of research integrity and publication ethics, and how we can do better in terms at like kind of the institutional level and at a broader level as well. So next slide, please. So research integrity is based on 4 fundamental pillars being honesty, transparency, reproducibility, and accountability. So are we actually presenting research as it is? Are our results what we claim them to be? Have we clearly delineated how we've gone about conducting a study and how we've gone about drawing our conclusions? Has this been independently verified? Are the means for this to be independently verified available to anyone who would want to do so? And at the end of the day, if there's something wrong with this research, have we identified who's accountable for this and who could potentially correct mistakes? Next slide. And on that point, like mistakes in scientific research and in medical research run across a very wide spectrum. Some of this is just honest errors where we're human, we overlook something, we don't quite analyze something properly, and that certainly happens. And we can run the gamut from just having maybe not the best methodology or maybe not the best understanding of how to conduct research. We might do things a little subconsciously, selecting things, having our confirmation bias, to more serious issues like having undisclosed fictional cases in a journal, or just straight up having fabricated and fraudulent sources and making up things that just aren't true or not supported by the literature. So it's not to say that everyone is a bad actor and that the issue is pervasive lying to us and to the public, but just sometimes mistakes happen. And then when mistakes happens, there's kind of 3 comments we should all be on the lookout for in journals, and those are corrections, expressions of concern, and retractions. And so what each of those means, correction is essentially saying that something's wrong with this paper, And if you see that, it should just trigger you to think, okay, I'll just be a little bit cautious about what's been presented here. They've obviously fixed whatever's wrong, but it should maybe, if something else seems off, it should maybe just question that something might have gone wrong. Expressions of concern means that there's a very major issue that is likely under investigation, and you should really be skeptical about anything that this article is telling you until otherwise confirmed. And then retraction is just plain and simple. This was wrong. These findings are unreliable. Do not rely on them. Do not use them. Do not put them into practice. Do not put them into guidelines. And the next slide, please. And with retractions, what's helpful is that we do have Retraction Watch, which is an independent organization. So it's outside of the academic process. And they're really looking and monitoring and keeping track of retractions in journals, just so we have a consolidated resource to help promote transparency. And for us, at least, it's a good way to kind of look at what might be retracted. And if there's anything controversial that we're hearing about in practice or through our own professional circles, it's a good resource for us to kind of go into and confirm what we're hearing. Next slide, please. And the issue with retractions is that, as Nasreen kind of alluded to earlier, the process of getting something retracted is not instantaneous, it's slow. And while things are under review, they can continue to be cited. Corrections to it can be delayed, and oftentimes they've already been implemented in things like governmental guidelines and medical education. And correcting things once they're that pervasive becomes much more difficult. So it's kind of another reason why we should be a little bit more on top of things like retraction. And then so to get to kind of the question from earlier, should these cases, these fictional cases, even exist in journals? I feel like most people would probably say no, but some people might quite reasonably say yes. Maybe there's some educational value behind them, but even in those cases, is disclosure sufficient? Are potential education benefits worth the risks, especially knowing that if there's a problem with this identified later, undoing that education might be difficult? And who is supposed to be held responsible ultimately in these cases? So just some questions for folks to ponder. I don't know if anyone has any
Yeah, I'll just throw that out
big
to the
idea they want to share.
audience. Sim, I'll just throw that out to the audience
Yeah,
because I do
yeah,
think people do have some strong opinions on this
yeah.
These are people who think
for educational purposes.
like,
Yeah.
for my case, they're fictional, or they were.
Or just here in live, and basically we asked everyone, do people think that fictional case reports should exist, even though they're based on education? Okay.
They can disclose that this is not a real case placed for educational purposes. I don't see why not, as long as it's clearly documented.
We got some people saying that as long as it's clearly documented that this is a fictional case, then it would be all right. Any other opinions? Yeah.
I think like maybe in a textbook, like not in a journal.
We have an opinion that we shouldn't put this in a journal. Textbooks for learning would be fine. Maybe discussion on the words, but not in like these journals.
I think our fictional case has changed the way that we practice medicine. So many outcome came out of that case. So.
Yeah, Knife is just alluding to the first part of the presentation when I spoke about that Lancet 2006 journal, how it affected pediatric children's and health in Canada, and how this case report actually affected policy with the FDA, Health Canada, and the Obstetrics and Gynecology College. So it's just that how one fictional or misleading case report can actually affect policy, and even though that was retracted, it still affects the policy.
Earlier Lancet article with autism and vaccines lingers on.
Yeah. And Dr. McKenzie's just
Mhm.
saying that the effects linger on from the earlier article. Yeah.
Yeah, I was just gonna add on like that case exactly, like
Yeah.
even baseline like actual case reports and actually like peer reviewed
journals and their articles are like already misinterpreted by the general public. So like I think adding fictional cases is just like adding confusion for no reason.
So we have a comment that even case reports in journals that are true can also be confusing and misleading. So when you add fictional case reports to that stuff, it also becomes even more.
It's getting quite heated in here.
People have opinions, which we expected, because some people believe that, as long as it's disclosed and it's for a learning opportunity and it kind of shows things that have been previously proven to be true, they can use it for educational purpose. Some people believe we have enough material that we don't need to do that. I'm not sure if there's anyone online that would have anything to add. I can't really see.
The chat.
I
I
was
don't
like,
see any hands, but
how can I look in the chat? Okay. That's okay.
oh wait, no, Dr. Zemek has his hand up.
Yeah.
Yeah,
I,
so I just a few high level thoughts, and I'll speak as someone who leads guidelines, so I completely understand the importance of that. I have used and am demonstrating an update to a guideline, a case vignette that's been clearly disclosed that it's based on a compilation of patients, more to tell a case story rather than for example, a person with a concussion. And I think the reality is sometimes to use a true case, you need obviously there's privacy and ethics considerations in which you now need to get the patient's permission to use a real case. And I think there are some journals that require you to put this into a context of how it would be applied clinically. So I think there are some instances where because of privacy considerations or others, you need to be careful. I think the bigger point that the take home that I hear from the conversation earlier is you should not be changing practices on one case, whether real or fake. It needs to be done in large points. Can I also just make one other point while I have the mic for a second?
Of course, yeah.
I know we were talking about corrections. I have, when you publish enough, you're going to get corrections. I've had a paper in JAMA that's required a correction. It was a transcription error in one table of one number, and it required that. And I think it's JAMA is certainly quite a good journal, and I think it's better to have something proactively corrected by the author when you notice the mistake yourself. And I think to say that it should be discounted is. It depends on the situation of why it required a correction. If you noticed it yourself and you want to do that, it almost shows a higher level of scrutiny as compared to something that is retracted. So I would just, for the listeners of the grand rounds, I would just be careful to say I wouldn't discount something that's had a correction, especially if it's author initiated and explained why. So I think those were just two high low. And this is not a critique or a thing. I just would. Retraction is a completely separate category than correction, and just flag that. I don't know if others have thoughts or comments. I'm willing to disclose I've had a thing corrected, but it was something I initiated myself because I didn't want to mistypo.
The wisdom of Roger. That's very good.
Alex McKenzie. Alex McKenzie did the wisdom of Roger.
It looks like Dr. Speckert has his hand up as well.
Hi, guys. I feel the same way that the presence of a correction shouldn't undermine the quality of the work. And I think the absence of a correction shouldn't reassure you that there isn't a mistake in there. I think we work in a fast-paced world, and I think it is, I don't think there are a lot of people going over their work again after it's been published to make sure there's no mistakes. So that's one point. And then the other point is, why do you think this happened? Because it's very easy for us to sit here and be like, but of course you don't change policy based on one case. Why would you do that? But the people writing these guidelines know that. So why did this case influence policy at the level of the FDA?
That's a great question.
Yeah.
That is a very good question.
A lot of people are saying great question.
They're not, why was it one singular case?
Yeah. And then there's another comment why was it one singular case report that changed policy? And it wasn't like the policy also just took away the Tylenol 3s. The policy had impact on pain medication afterwards that were more addictive and potent for mom. while she was breastfeeding, and we don't know the effects of those medications as well.
The author of that paper was also involved in the Mother Risk program at Sick Kids, which had a very controversial, influential, in a bad way, past as well. So there's a bit of a pattern here with Dr. Collins.
Okay. I'm just going to move on to the second question because it was mentioned that if it was disclosed that it was fictional, that would be okay. Do people feel like that would be enough for you to be critical of it?
It has to be bold so that the reader cannot miss it. If you're talking about telling them that it's fictional, I think.
I think there's a place for fictional cases and it's on educational websites. It's not in peer-reviewed literature where clearly there are regulatory agencies that, I think that there's an understanding that some sort of scientific and evidentiary standards in peer-reviewed literature.
We just have a comment that there are places for fictional case reports, mainly in like education, but not in like peer-reviewed reputable journals where we expect true cases.
Another like big thing like that I'm thinking about is like AI is becoming more pervasive everywhere, and a lot of these AIs are based on databases of journals, of peer-reviewed journals. We have fictional cases gonna make things up. Like, I mean, it's already making things up at baseline. Now we're adding like more fake information. Like, and it's like it's not something like we could just say like, oh, we're never gonna use AI. Like AI is already in everything we use, and it's just gonna continue like being there.
There was a comment talking about AI and how AI has the databases and it uses the journals for these databases, and that we can't really stop AI from being used because it's only going to expand. And that's also a risk.
And then just online Dr. Zemek has
Dr.
another
Zemek,
comment, I think.
Yeah, I was just going to make a side comment. Sometimes there may be a side benefit though of removing codeine, regardless of the fake information. I mean, as an emergency physician, we do see a lot of people in pain, and a few high-level teaching points on that. There has been a good study through the Pediatric Emergency Research Canada. Samina Ali is the current chair, and she's spent her entire career studying pain management, and there is in the acute management of pain, Advil and Tylenol are just as good as even straight up opioids, including morphine. And given the fact that, as you discussed in the beginning of the case, there are fast metabolizers, there's also non-metabolizers. And so if you give it to someone who's a non-metabolizer, now you're giving something that you think is going to be effective, but is not. So while I'm not certainly advocating we should be putting codeine back on the market, there is some benefits of the fact that we remove codeine in general from at least pediatric care because of the fact that you would not know in the emergency room for whom it would work too well. So I think it's better just as a principle to address pain. And again, in general, if you do need to treat, morphine is certainly the safer opioid just because then you know what you get compared to codeine with regards to requiring a metabolism. So I think it was just another side point with regards to well, the way it was changed was, as you've so eloquently put, necessary to be reflected upon and make sure we don't repeat those mistakes. The fact that codeine's off the market is not upsetting to me as an emergency physician treating people in pain and not knowing what was going to happen.
Excellent.
I'll just move on. And if we are using fictional case reports, are the educational benefits worth the risk? And if these do come out finding that there is a big problem, who would be responsible? Is it the person telling people this fictional case report? Is it the people who are using this fictional case report knowing it's a disclaimer with a disclaimer?
It's a good open-ended question. Who is responsible? Responsible for what, Sim?
I guess who?
So, I mean, who, like in this case, particular, like the physician who published all of this, ultimately like left the country and hasn't really responded to comments about the original publication as well. So in terms of like all of these downstream effects and all of this impact that it's had on so many things, like who is ultimately like who should we kind of look to as
Is a systems failure of originally the individual generating the data, sending it in, the publication not, when the case of the Lancet, the publication not reviewing it meticulously, and then, that's in the Lancet. In the case
In
of
the
the,
pediatric journal.
I mean,
Yeah.
I kind of
And
see like here, every step of the way, like something went wrong as far as confirming this and maybe limiting some of its potential impact, but
yeah.
okay, I'm gonna move ahead.
yep.
Okay.
Yeah, and so just in the interest of time, we'll kind of just finish the last few slides. So really all of this is to kind of underscore that not having a good approach to how we're evaluating research and implementing it kind of undermines public trust in medicine. Obviously our patients look to us kind of as authority figures and are trusting us to a very implicit degree about what we're saying and recommending. So how can we kind of safeguard that moving forward? And especially as someone said, in the era where technologies like AI are threatening to kind of undermine our authority and give patients access to resources and knowledge that they may not necessarily have the context to process themselves. And the idea that maybe we need to just be a little bit more humble in what we're thinking and saying, and kind of acknowledging that sometimes we don't know, we can't ever know for certain what exactly is going on, and just being transparent about how we get to our conclusions. And then finally, kind of the big takeaway here is what's the framework that we can use to actually help us evaluate research. So just on the slide. And so remembering that literature is imperfect. So what is our approach to figuring out where those imperfections are? So we'll present that here. And essentially the framework we found, next slide, please. Yeah, perfect. Is actually appropriately given the acronym TRUST. So transparency. So have the methods been made clear to us? Are the disclosures regarding bias and conflict of interest and limitations also present within the paper itself? Is there any reproducibility here? And then U for underlying plausibility, but really the idea is plausibility. Is this something that's physiologically possible? Is this something that's reasonable to conclude based off of the science of medicine? S is for strength of evidence. So what type of study is this? Is this something that's in the unfiltered category versus the filtered category? And then finally, still learning to translate things cautiously. Just because there's a major finding doesn't necessarily mean that your practice needs to change immediately. Ask yourself the question, is this something that's significant enough that I want to implement it now? Is this something that I can gradually implement and see how patients respond? And is it something that's already kind of being represented in guidelines and gives me a bit more knowledge of how to practice it? On the next slide. And then finally, just on the last point, before you're going to consider changing anything, always ask yourself some more big questions. Was this a single study? Is this based on a body of evidence? Is there already some consensus emerging around this, especially from specialists or from societies? Are there potential harms associated with it? And are the benefits justified? Do the benefits justify the harms, or do the harms justify the benefits? Is this being explored at kind of a larger level and through guidelines? And does it actually apply to the patients I'm seeing? Does it actually apply to my practice? Because if it doesn't, probably not something that you need to be too fussed about changing. And then just a few final points, so especially through our lens as residents and trainees, things that we can kind of do as learners, so either as residents or as students, just approaching these problems with a bit more intellectual curiosity, asking questions and kind of going back to the primary sources and seeing what they're saying and confirming if that accords with what we know or what we think we know, and being more open to discussing uncertainty and kind of accepting that this is kind of just inherent to how we practice medicine.
Does this mean that the attending staff can be intellectually arrogant?
I will let attending staff decide that for themselves.
Ignore me.
Sim says he'll let the attendings decide for themselves.
And then what can we do at a greater level in terms of institutions? So number one, the biggest thing is teach appraisal skills. So teach things like this trust framework. Make uncertainty a bit more of a normalized practice, except that it is something that is inherent to medicine. And then encourage being transparent about how we do research and support things like corrections. And I think, kind of as Dr. Zendik and Dr. Speckert were saying, it doesn't necessarily have to mean that the research should be thrown out, but just to, if there's a correction, look into why it's being corrected and what that means about the study as a whole. And I believe that takes us to, yes, so kind of the big things here. So number one, just to remember, peer review is a good part of the process. It's necessary. It's not a bad thing. We shouldn't be getting rid of it. But it's not perfect, and it doesn't necessarily answer the idea of should we trust this study. Narrative cases can have a lot of power. They can be very convincing, but they're not always best in terms of evidence quality. And the quality of a study should matter more than where it's published. And the integrity in research sounds like a very disparate consideration, but ultimately through a cascade of series, it does affect bedside care. It does affect how we practice. And if there's one thing I want people to kind of take away is learn to have a structured approach to being skeptical, but don't be a cynic about it, because then we'll never fix these issues and we'll just set ourselves up to keep perpetuating the same problems. And I think so just a nice little quote about how to implement evidence-based medicine. So remember, there's still a part of this that requires your own judgment, so don't just rely on what everyone is telling you. And then I think we have a couple more questions for just some discussion points. But otherwise, that is it for us. Thanks for attending, everyone.
Thank you. Yeah. So we can ask these discussion questions. Is there another paper that's ever changed your practice prematurely? And I can talk about one of the papers we discussed regarding allergy. So a while ago, the standard was that actually we don't introduce allergens like high allergy food, like peanut butter, shrimp, and these things until the child are way older. And then we saw a huge rise in allergies. And when we look back from where this data came, actually it was more expert opinion. There was never a study actually done. And based on that, and then systematic reviews done later, now early exposure to allergens are appropriate.
The church in AAP in 1999 published eminence-based sort of advisory to avoid in the first 6 months all dairy, peanut, seafood, and there was a spectacular rise in allergies. And
6 months to 12 months, like the early introduction. Yeah. Yeah. And then there was a huge rise.
and it took 2 decades for
We completely, oh, sorry.
No, you go ahead.
No, we completely flipped the guidelines on that. Like now it's early introduction is the best. Tolerance from the immune system happens with controlled exposure rather than no exposure. Yeah. So there are a lot of papers out there that have changed practices that are really surprising, actually. And,
Sorry, can I push back, Sim, on the trust, the reproducibility, and the biological plausibility? Sometimes you're the first people finding something, and so I worry that if we just ask all the time, is it reproduced elsewhere? We get caught in a loop. So very rarely, people are finding new biology, more in biomedical than perhaps clinical, but new stuff that hasn't been seen before. And the most important stuff is biologically not plausible sometimes. It turns out a whole paradigm inversion. So for the TRUST acronym, I'd say maybe showing it's been reproduced elsewhere is not a hard and fast, I guess. That's a minor quibble.
Yeah, I think that's fair to say, especially if you're looking at something that's kind of niche or a bit more of a rare disease. You might not necessarily have the ability to reproduce that So sure, maybe not a hard and fast rule, but certainly if it is there, I think that can help increase your confidence in something.
Yeah, Malika.
Well, I kind of like
A counter.
something that happened once, and then within ethical, I guess, limitations, like they try and reproduce or like see where it can reproduce other things. But I think for clinicians, typically it should be reproduced. Like you should have multiple instances of it.
We have just a comment that like yes, being the first one maybe a little more for researchers, but using it as evidence for clinicians, it probably should be reproduced.
Yeah. I mean, so you should not say it's not true, but you should not change practice. But as Rogers and others said earlier, you shouldn't be changing practice on the basis of one case study or even a small number anyway.
Mm-hmm.
And you shouldn't be changing practice on the basis of non-evidence expert consensus as, at the other end of the spectrum.
Yeah.
There's a comment.
I
You're doing the moderator job as well. You're
I
killing
know.
it.
I'm like, how do I see the chat? Sam, can you read the question if you can see the chat?
Yep, I can. 1 second.
Word.
Actually, no, there isn't a question, but Dr. Speckert has his hand up.
Okay.
Thanks. I want to know what your thoughts are on where the journals fit into this, and specifically like a fairly, on one hand, effective model of distributing research, but one that is for profit and somehow has managed to create a pipeline whereby research which is done for free or with grant money from governments is somehow like given to journals to sell back to researchers for money, and everything that happens in between is kind of done pro bono. So like the peer review process, depending on the journal, I'm not aware of a journal that pays for peer review, but it might be out there. The peer review process is somebody like me gets an email that says, hey, we have a paper we think you should peer review. Please respond within 7 days to accept or decline this. If you accept, then they say, hey, please submit your report within 11 days. And here are our guidelines for peer review. And that's it. That's what a peer review is. It's you read through the paper for free on your own time. And depending on how much time you have to dedicate to this, like you're signing off on it. Are you checking every single citation that they've included? There is a certain amount of implicit like trust that the
Dr.
person
McKenzie's excited.
is like
Stop whining,
being
man.
honest.
I can feel Dr. Mackenzie's excitement through the computer screen.
I'm sorry, I'm new to this. So if I've said something that's wrong,
This is the
just
world
how
you
I
signed
feel.
up for, buddy. Yeah. And then if you're the author submitting to something like Nature, you're paying $5,000 out of your budget to have it peer reviewed. So no, if the question is, and I'm sorry, is the peer review system seriously effed? Yes, you're absolutely mad. It's badly broken. And so you want Sim and Nasreen to sort it out? Or what's the question?
We're just facilitating this conversation.
I don't know if
it's
I have
not
an
a
answer
fair
to that.
question.
But
I just think there's a lot of like the researchers submitting their work and the people reading their work, and you're like, the whole system is a little bit like profit driven, like
Yeah.
it's driven by novelty, wanting to be on the cutting edge of things. And then on the other hand, you have social media where people are pulling these cases and being like, babies are dying of opioids. What are you going to do about it, FDA? And so it's, if you move too slowly, then you're damned. And if you move too quickly, then you're damned.
Have we turned into a Joe Rogan podcast at this stage? But no, you're absolutely right, Matt. It is a bit. People are sort of working on it and discussing it, but there's no quick fix in sight, and it is flawed, 100%. We feel your pain, especially me and others, Rogers and others who do the research a ton. Yeah.
And you have your hand up? Oh, sorry.
Go ahead. I'll sit down.
Oh, no, I saw Dr. Zemek. Was it? Maybe not. Okay.
Yeah, I did. I had raised my hand. I think it's always anything is there's no such thing as a quick fix. I think the reality is we know that even the best evidence takes 15 years to get to bedside. So I think for everyone, some of the most important discoveries still take way too long to get into practice. Yet at the same time, we need to make sure we move carefully, and I think that's that fine balance. And I think that's just point number one. Point number two, just to tie back to the journal stuff, I am while I am worried about obviously the use of changing practice on a case report. I am probably as a scientist more worried about the use of AI in writing journals. One thing I have started to do very carefully as a peer reviewer is look at the references, and it is shocking when you see how it hallucinates. I just as a case vignette, I collaborate. When I was the chair of the PERC network, the past chair was Stephen Friedman. He does a lot of stuff on GI research and infectious disease. He's the one for any of you who give ondansetron for kids with vomiting. That's his study, and he was peer reviewing a paper recently that had a list of it listed Friedman and Zemek and that because we've collaborated on things. It was a completely made up study. My study was the 5P. His study in the peer review he was reading, the journal reference said it was again JAMA said Friedman, Zemek, the 4S study, and it completely made up a new study combining his study and mine. And it was at a good journal that sent it to him to peer review. So I think we need to be real. While I am certainly worried about obviously all the stuff you talked about today and changing practice, I think it's really important to make sure we're careful about that. And second, going back to Matt's point on peer review, I also really worry when people who are not experts in the field are peer reviewing things that require content expertise. And I know recently I was discussing with another colleague, there was a paper that had 6 reviewers for PLOS, and the person that rejected it was a non-physician who studied mice in the lab, and it was talking that this paper needed to be rejected because of the fact that they didn't use translators to enroll patients, and they shouldn't have been excluding people who didn't speak English or French, which, as all of us know, people need to understand consent, and there's ethics and all those things. So it's just careful. It's fascinating when you really dive deep into the world of peer review, how many potholes and potential dangers you come across. And I think there's lots of challenges. So you could spend 3 hours talking about this.
Oh, just did. Just joking. Thanks, Roger. I think we're at time.
Yeah.
Yeah.
All
there's a
right,
question
let
in
me
the chat.
open the chat.
It's a
Oh,
committee approach.
sorry.
You-
Wait, I'm trying to open the chat. Wait.
I've got it open, Esther. I can.
Oh, thank you. Yeah, I'm a
So we have
bad.
a comment from Dr. Major.
Yes.
So sometimes we don't have full evidence and it's difficult to establish practice. And as an example, she talks about using steroids in children presenting with meningitis, whether or not we should give it because in certain bacterial processes, it can reduce the risk of hearing loss. And then from Dr. Kachadorian, I think it's important as well to look at letters to the editor for the article or in some other journals. Some authors have lost trust in the peer review process for controversial topics such as pediatric gender medicine. And she's actually pointed out that there's a journal called the Journal of Controversial Ideas that exposes censorship of debate in gender medicine. And she has lots to say about this field. We want some skepticism on that, which.
Great.
Yeah.
Okay. I think we're at time. I want to thank you guys for really an excellent presentation and moderating as well, and just a lot of interesting conversations. Thanks very much.
Thank you, everyone. Thank you.
Thanks.
Bye. Thank you.